initiatives. February is American Heart Month, a time when an emphasis on cardiovascular health is placed. As we end Heart Health Month, we pray that the information and resources shared today will enable cardiovascular health for all. Thank you to our physical and mental health and social action chairs, co-chairs, and committees for a wonderful and informative program. Once again, welcome. I now turn it over to Ms. Christian Lynch-Grimes.
Good evening. Dear most gracious Heavenly Father, I come to you humbly, acknowledging the magnitude of your spirit and the power of your peace and of your presence. Thank you for this opportunity to share and learn about how we can be better stewards of our bodies. Thank you to our speakers for today and for all of the participants and attendees. And I pray that we may hear something that will improve our lives and improve the lives of others as we share our knowledge about heart disease and the disparities that so greatly impact our community. Let us open our hearts to receive that which you have to impart to us through the words of Dr. Courtney Phillips and Dr. In Jesus' name I pray, amen.
Well, thank you very much for that prayer, Dr. Grimes. We appreciate that, and good evening and welcome once again. On behalf of a very busy Sensory O'Rourke Allen, who's a local dentist here in the Baton Rouge community, she is unable to join us in her official capacity as the proud president of La Capitale chapter of the Links Incorporated. I am humbled to offer words of welcome in her stead. The Links Incorporated is an international not-for-profit corporation established in 1946. The membership consists of more than 17,000 professional women of African descent in 299 chapters, located in 41 states, the District of Columbia, the Commonwealth of the Bahamas, and the United Kingdom. It is one of the nation's oldest and largest volunteer service organizations of extraordinary women. Links members contribute more than 1 million documented hours of community service annually, delivering impactful programs through 5 facets: services to youth, the arts, national trends and services, international trends and services, and health and human services. And tonight, we are honored to have 2 powerful presenters that will offer educational information that will be impactful for our audience. Once you hear their bios, you will certainly understand how fortunate we are to have them take time out of their busy schedules to be on program this evening. Now, I would be remiss if I did not mention that Dr. Phillips is a dedicated and hardworking member of La Capitale chapter, and Dr. LaMotte is married to yours truly, a member of La Capitale. Dr. Phillips is laughing there. Yes, we are utilizing our roster this evening. We would also like to thank each of you as our program attendees for your time this evening. We realize that time is a very precious commodity, and we are sure that your decision to spend this evening with us will be beneficial and enlightening. I would also like to extend a special thank you and hello to some of my students, the health law students here at Southern University Law Center. I'm sure that they are eagerly watching tonight's webinar. Lastly, a sincere thank you to the ladies of the Baton Rouge Delta Alumnae chapter of Delta Sigma Theta Sorority Incorporated for this partnership. We look forward to future programming or opportunities as we both seek to improve our local communities. And with that being said, let's turn to tonight's agenda. Ms. Deanna Matos serves as co-chair of the Physical and Mental Health Committee for Baton Rouge Delta. She will provide some housekeeping tips for everyone, and we will then hear from Dr. Courtney Phillips for her presentation. She will have a Q&A session after her presentation, and then we will move into Dr. LaMotte's presentation, followed by his own Q&A. I will now turn the program over to Ms. Deanna Matos. Matos?
Thank you, ma'am. Good evening, everyone. Just some brief announcements. So the chat is going to be disabled. However, you can put any questions. There will be a question and answer box. So any questions that you have while the panelists are speaking, please feel free to put it in the Q&A box. Please do not attempt to put it in the chat, as the chat will be disabled for the duration of this program. Once each panelist is done, then we will pose the questions to them to answer, and they will answer the questions directly. Thank you.
Thank you very much for that. And we are just going to say very quickly, Delta Sigma Theta sorority was formed on the idea of being a force for social change. Baton Rouge Delta Social Action Committee is led by three phenomenal women, Attorney Yorshika Butler, Judge Tamikio Garrison, and Ms. Courtney Hunt. I thank them for allowing me to represent the committee on tonight's program as we add a social action component to the heart health information and provide a focus on equity and access considerations. To that end, I am excited to introduce my link sister and friend, Dr. Courtney Phillips. As Secretary of the Louisiana Department of Health, Dr. Courtney N. Phillips leads the state's largest agency with a budget of $19.1 billion and a team responsible for delivering services to millions of residents of Louisiana. LDH protects and promotes health for Louisiana residents through services provided by Medicaid and the Offices of Public Health, Behavioral Health, Citizens with Developmental Disabilities, Aging and Adult Services, and Emergency Preparedness. These programs work to ensure access to medical, preventative, and rehabilitative services for Louisiana's most vulnerable residents. Prior to her role as the LDH Secretary, Dr. Phillips led 2 state health and human services agencies in Nebraska and Texas. Dr. Phillips returned to Louisiana in April 2020, becoming lead of LDH amid a global pandemic. Under her leadership, the department has received national recognition for an innovative response to the pandemic. She has also developed and implemented a forward-thinking business plan to improve an array of LDH services for residents, including mental and behavioral health services, among others. Dr. Phillips holds a bachelor's degree in kinesiology and a Master of Public Administration from Louisiana State University and a PhD in Public Policy from Southern University. She has earned an executive green belt in Lean Six Sigma. And with that, I present to you the incomparable Dr. Courtney Phillips. Dr. Courtney.
Thank you, Ms. LaMotte. And good evening, and thank you everybody for joining tonight. I do want to thank the Baton Rouge Delta Alumni Chapter for Delta Sigma Theta for hosting this event, along with the Capitale Chapter for the Links Incorporated. Let me just say, when we look at the state of Louisiana and where we are with health, the importance of organizations bringing folks together to have these conversations and to be able to receive information is a step in the right direction for us improving our overall health here in Louisiana, but particularly our heart health. And so with that, I'm gonna just jump on into my presentation. And Ms. LaMotte, you're gonna run the slides for me? And if we could go to the next slide and we'll jump right on in. And so understanding this conversation as highlighted this month is Heart Healthy Month, focusing on heart disease. And it's an important topic when we think of healthcare overall, because heart disease is preventable and it's so impactful in terms of our overall health. But most importantly, it is preventable. And so when we think of the leading cause of both men and women, it's heart disease. Across any racial and ethnic group in the United States, heart disease is the leading cause of death. So it outweighs cancer, accidents, strokes, and other causes of death. But here in Louisiana, as you all know on this call, we have much work to do in our health overall. We have higher than average rates in terms of most of our chronic conditions, which includes cardiovascular disease, diabetes, high blood pressure, and I could go on and on in the list. For those 3 main chronic diseases, we rank 40th out of, or lower, out of the 50 states for those 3. When you think of cardiovascular disease and where we stand for Louisiana adults in comparison to the national average is 8% of adults have cardiovascular disease. Here in Louisiana, we're at 10.2%. So we are already behind just as a state of adults in terms of cardiovascular disease. Next slide, please. But let's go a little bit further in talking about Louisiana, because we know we have work to do here across healthcare and health and heart disease. But if we really want to talk about improving and addressing our rates of heart disease, we have to, one, focus on all Louisianians, but we have to take into account and focus on the health disparities that we see with most chronic conditions. Cardiovascular disease is no different in terms of where we rate as it relates to heart attacks, strokes, and other chronic diseases here in Louisiana. Diseases are not felt equitably. So when we talk about the disease, we have to go a little bit further and just say in terms of Louisiana has to be improved in terms of health disease. We have to look at where do we stand in terms of racial disparities. And sometimes that's a hard conversation for folks to want to focus on. We say we want to apply our resources equitably. Well, the reality is the disease is not hitting us equitably. So we really do have to dig in terms of those data points and focus in where do we have to focus our resources. Studies have found that Black adults in the United States, we're at greater risk for heart attack, stroke, cardiovascular disease, and other chronic diseases. Louisiana is no different. So again, when I look at the rates in terms of cardiovascular disease for Black adults in Louisiana versus white adults, 9.8% of white Louisianans are at risk of cardiovascular disease. Now let's look at our population. We're at 11.4%. So again, we are falling behind. And so we have to take that intentional focus and be aware of where we stand so we can take intentional focus and efforts individually. Now, for Black women, we're at a higher prevalence for heart disease than any other intersection of race or sex in the United States. That's a standout. So we talked about, one, living in Louisiana, we're at a risk because we are falling behind on the national average. As Black Louisianans, we're falling behind in terms of our white counterparts here in the state. As Black women, we have an even higher risk that we need to put some intentionality around that piece as well. And so what does that look at overall? So let's talk about in terms of two particular things that also impact cardiovascular disease, those conditions, high blood pressure and stroke. And again, we are at a greater risk. We are almost 2 times more likely of a stroke than white women. In addition to that, we are more likely to die at an earlier age when comparing to our white counterparts of any ethnicity. In the US, nearly 58% of Black women have high blood pressure in comparison to 41%. And I share all these stats with you because they are alarming in terms of where we have to put the focus and the awareness. When we look at in terms of 58% of Black women with high blood pressure compared to 41%. And of that population of Black women with high blood pressure, only 20% have their blood pressure under control. So even after we are aware that we have a higher blood pressure, the ability to control it and have ongoing care is still a struggle. Next slide, please, Ms. LaMotte. So one piece that you all have probably heard about and heard the word thrown around, social determinants of health. And so when we think of social determinants of health, and it's important because in order to address disparities, we can't just focus on the pure number of where we are in terms of those percentages. We have to understand what's happening behind the scene. And this is where social determinants of health play into it. So when you think of social determinants of health, what are all the social and economic conditions that affect our overall health and well-being? We have to think of things of housing, transportation, neighborhoods, education, employment opportunities, income, the access to nutritious foods, the opportunity for access to healthcare in a convenient manner, physical activity opportunities, basic things like clean air and water in terms of proximity of where you live. Those are all things that have to be taken into account when we talk about we want to improve the overall health of Louisianians and focusing on the population who has the lowest rates or the highest rates in this manner. Another piece that we have to consider, and sometimes we don't like to talk about it, are there other factors that play into these social determinants of health. And so factors such as exposure to racism, discrimination, violence. Other risk factors are also important. Poor diet, physical inactivity. We can talk about tobacco use, inequitable access to nutritional foods. And the list goes on of things that have to be factored in and being aware and making those differences. So when we look at smoking, diet, exercise, social and economic factors, those are primary drivers to healthcare overall. When we want to talk about outcomes, those are the drivers that lead to the outcomes. This can shape our overall health behavior, from very early on in our life. And unfortunately, here in Louisiana, we have higher rates of each of those things that I named. We have higher rates of obesity, higher rates of smoking, have higher rates of overall tobacco use. And again, these things can lead to preventable diseases. We can do it. It just is going to take a very intentional effort around it. Kim, next slide, please. When we think overall, just in terms of some of the influence of cardiovascular disease, I mentioned diabetes and hypertension. Again, those are two factors that are great risks for cardiovascular disease. Again, they're preventable. We should need to focus on early detection and treatment. All of those three things are achievable and critical for our overall health. If we want to talk about reducing disparities, again, prevention, early detection, and treatment. Oftentimes we have the highest rates, but we also have the higher death rates around it because we're detected later on in life. And sometimes that treatment may not be equitable when we're going in. So one of the things that we took focus on and Ms. LaMotte highlighted is us launching a business plan here at LDH. And one of the things that we highlighted last year was our focus on emphasis in terms of improving and lowering the rates of chronic conditions here in Louisiana with a focus on racial disparities. Again, we cannot ignore that fact if we want to improve overall. So again, understanding that the state struggles with these particular diseases, we want to look at how can we make those improvements. Diabetes and blood pressure leads to things and risk factors of cardiovascular disease. So let me give you just two stats in terms of diabetes and high blood pressure. When we look at Louisiana adults, 13.6% have diabetes. Again, the national average is 10.9%. When we look at Louisianans that have high blood pressure, the amount is 40.2%. The national average, 32%. So you see the theme here. You see the consistency of a national average, Louisiana is higher. And then when we go further in terms of the data, in terms of Louisiana, and we break it out by demographic data, Black Louisianans have a much higher risk and a greater propensity to these diseases. So one of the things that we outlined in the business plan, we really wanted to learn from some of the things that we were doing in COVID. And we looked at a lot of the lessons we learned were working with community partners, getting out to where individuals are, and understanding what the need was, meeting people where they are, not just expecting folks to come to brick and mortar buildings. Granted, that healthcare is absolutely needed and we have to increase it, but also how do we do more community-based services? And so one of the things we launched last year was community-based blood pressure monitoring stations, as well as diabetes prevention stations. Now, we just started, and so we have 10 community-based blood pressure monitoring stations across the state and 6 diabetes prevention programs. We don't have one here in terms of the community-based blood pressure in the Baton Rouge area. If you are interested overall in terms of whether it be your church, your community organization, housing one of these sites, again, we do them in barbershops, gyms, veteran centers, other spaces where people feel comfortable, reach out to us. And I'll give you my email address at the end. This is the best way that we can do some of these initial screenings and then refer folks to a healthcare provider. The more and more we can make individuals comfortable with the information and getting screening, that's what that early prevention is all about. Ms. LaMotte, if you could go to the next slide. Again, this was under our LDH Well Ahead initiative, and you can see on the slide, just looking at where some of those locations are highlighted. And so this particularly is for the diabetes prevention. You can see on the diabetes side, we do have a location in East Baton Rouge and a couple right around the East Baton Rouge area. But again, this was starting off with 6 sites across the state. And so I kind of pulled some of the closer areas to Baton Rouge. We have much further that we need to go in terms of expanding and increasing the number of sites across the state. So we want to capitalize and work with the entities that we worked with during COVID. We saw great success by getting out and about into communities and moving away from locations where we didn't have those brick and mortar buildings, but reaching folks where they are. And I think if we apply that same intentionality, we can see improvements on our chronic disease side as well. Let's move to the next slide. We talked a little bit in terms of obesity, nutrition, and physical activity. And that plays into our overall health overall. And again, it's a risk factor. So if you have a poor diet, if you smoke, if you're physically inactive, all of those things are risk factors in terms of our prevalence for disease. And so how do we work to really combat that? And again, let's look at the rates in terms of national average versus Louisiana rates for both obesity. So when we look at adults in terms of the national average for obesity, 33%. We look at Louisiana, 38.6%. Well, let's look at our youth. Youth national average for obesity, 17%. Let's look at youth, Louisiana youth, 24%. Part of what that data tells us is that we have to start much earlier in terms of educating our youth. One, on where they stand in Louisiana in compared to the national average, and then for our Black youth, where they stand in comparison to white youth. I think the more and more we share this information, we can arm our youth and our children to make conscious decisions very early on. I'm in my mid-40s, and I know it is much harder now for me to adjust and make some of those changes than it was very early on in life if I had adapted some of these behaviors early on. And so understanding where we stand, how do we change some of the influence we have on our children in terms of the selection of nutritious elements that they're taking in terms of their life, incorporating physical activity early on so they can maintain that lifestyle when they enter into adulthood, introducing them to the various activities that they can do to maintain physical activity as they age. Those are things that we have to start introducing now to be able to help our children be ready for adulthood so they can come back and really break the cycle that we have been experiencing here in Louisiana overall. So when we talk about nutrition though, where are we headed with this? So we have been partnering with food banks, community gardens to really increase healthy foods in underserved communities. We're partnering with Southern University Growing Healthy Gardening Program that targets Head Start. It gets into schools, councils on aging, community centers, working with churches, making sure that we can provide access to nutritious foods, to sustainable, healthy eating, and really identifying those areas and investing in it. You know, working with the food bank so we can increase food pantry storage so folks have access to healthy meals so they're not having to choose an unhealthy alternative. These are all investments that we have to do more of at the Louisiana Department of Health to make sure we really are making the change that's going to drive to the outcomes that we want to see overall. Now, real quick, let me just mention another element that we are working on very early on with our youth in terms of childcare centers. And so we have a project that's called With Well Ahead, where schools can reach achievement in terms of achieving a well spot. And part of that means is that they have to meet certain benchmarks for both nutrition and physical activity. And this starts early on in childcare centers. Right now, we have about 282 childcare centers across our state that fall within categories 1 through 3 of well spots. Each year, we want to continue to increase those numbers by about 10%. And the hope for that is really if you are starting kids very early on, they will continue that with their lifestyle. So while you're making a change with the youth, with children early on, you're also providing that education to the family members so they can see, you know, is the ease of providing and doing nutritious meals at home. Sometimes we don't feel like it's convenient, that it's not an option for us because we're on the go. We have work, we have childcare commitments, after school activities, and we're grabbing the quickest thing because we don't believe that there's a possibility of a quick nutritious meal. And so how do we incorporate that much more so? Let's move real quick to the next slide so we can talk about smoking and tobacco use. Again, additional risk factors for heart disease. And unfortunately, Louisiana is pretty high up there as well in comparison to the national average. We're higher than the national average for both smoking. National average is 14%, we're at 19.5%. A couple of things that we're doing in this area as it relates to Medicaid. Historically, we've only covered tobacco cessation for individuals when they were pregnant. We have made a change this upcoming year that will go into place April of 2023, where we will expand Medicaid coverage for tobacco cessation for all enrollees, for all 2.2 million of individuals who are accessing Medicaid benefits. So that way they have access to tobacco cessation so they can assist in terms of weaning off and really moving forward to a healthy lifestyle. Sometimes you have to make that front end prevention investment, and that's in dollars also, in order to see the long-term outcome and that return on investment. So that's a piece that we're doing as well. Let's move to mental health on the next slide. So often we forget that mental health is a key impact on our physical health and we fail to talk about it. So when we look at the mental health factors that plays a part of physical health, it plays impact on cardiovascular and our cardiovascular system. The risk factors could be stress, anxiety disorders, mood disorders. All of that plays and weighs into what we need. And of course, mental health and heart are very common, among women and racial and ethnic minorities. And so again, another factor that we need to be aware of and combat. Some of the things that we're working on in terms of Louisiana is last year we rolled out, and we're working on it this year, is a continuum of crisis services. And so we added 4 additional services in terms of our behavioral health program for adults, where each region of our state will have these available services for an individual who's experiencing crisis, where you have a mobile unit that can come on site and assist that individual at that moment, that they don't need to be transported. In the event that that crisis is not able to be stabilized on site at their home or wherever they are in the community, we're going to be opening up 24/7, almost like an urgent care center. If you ride around, you see several physical health urgent care centers, but we don't have that specialty in terms of behavioral health. And then also increasing the short-term stay beds for individuals who need that immediate crisis inpatient stay. The next piece that you're going to see as we enter into legislative session, we're going to be working with our legislative body, along with the governor that he has in his budget, for an increase of behavioral health services for adolescents. Over the past 3 years, it's been really tough for us as a nation, but even more so for Louisiana, because in addition to COVID, we also face the winter weather storm. We had several hurricanes. We had a flood in Lake Charles. And so we've had numerous events that have triggered stress and trauma for our state. And so often as adults, we're trying to talk through it. We're trying to maintain, but oftentimes we forget about the impact of our youth because they aren't necessarily able to talk about it in a manner that we understand that it has impacted them as well, the compounding depression that they are feeling. And so that's a piece that we really want to make a heavy investment on this year, is the behavioral health for our youth and adolescents. One thing that you all may have seen about that the federal government launched a 988 suicide line. And so they want that to be anybody to be aware of. The state's always had a 1-800 number, and that's not a number that most people knew about, the suicide number. And so understanding, like if it was a 911, 211, those are all numbers that we know. We know it, our youth know it. And so creating a suicide hotline that folks can easily recognize and call when in need. And so the 988 suicide launched earlier last year, and a heavy campaign is coming about this upcoming year. And so there's more work to be done around that as well. And so if we go to the last slide, I just want to leave you all with a couple of things in terms of heart health and what you can do. And the onus is on us as well. And so part of it is to stay informed. We have to talk more in terms of the Black community of our family history around health and understanding what has happened generationally in terms of our family health. The more we know, the better we can prepare and arm ourselves and our clinicians to help us on a path of successful health. Take action. There's always going to be something to do on our to-do list that we say, we'll do that appointment later. There's always going to be something that comes up. But if you are not present, then your health will not be able to be maintained. So schedule your checkup, monitor your blood pressure, get your screenings as appropriate. And again, self-care for stress. The amount of stress that probably everyone on this phone experiences in the last 3 years is critical. We have to make sure we are implementing self-care and holding each other accountable for that. Sometimes I know I don't do a great job of that on my own, but making sure that we have peers and friends in our group that can hold us accountable to make sure we're taking care of ourselves. The other piece I would encourage you is to spread the knowledge. We have over 100 people on this call today. Each of us have our own group that we should share the information that we're learning today to others. Again, create a peer group that we can hold each other accountable and share information. And the last piece is really just prioritizing our health. I learned something on another engagement where one of the doctors shared that we should control what's controllable. And we have a lot of things in our health that we truly can control, and making sure that we do our part to do that. Remembering that mental health absolutely matters. It's a critical part of our overall health. And if we don't take care of that piece, it is going to weigh us down on the physical health. And so those are the action items I would have for you all to take back to others that you know. Again, I think over the last 3 years here at the department, one thing that we have recognized and have really worked hard to make sure that we put in place is that we know we cannot do this alone. Yes, we are the state health entity, but if we do not formulate the partnerships and put our resources together, we will never move the dial across our state. And I think, again, learning from COVID, the one thing that we saw in our state is that the intentionality we put in terms of vaccine distribution is why we're ranked as one of the top 5 states in terms of vaccine equity. Again, our overall rates for vaccine are not great, but when we would look at the demographic data in terms of African Americans here in Louisiana, we're what, 33% of the population here in Louisiana. And when we look at our vaccine uptake in terms of completed doses, we exceed the percentage that we represent here in Louisiana. We're at 57% of Black Louisianans who have completed, of that 34%, who have completed their vaccine dosage for COVID. Again, that didn't happen by accident. That's because we were very intentional of getting into the communities. We understood what the data showed in terms of what the disparity looked like in terms of death rates and who was catching COVID. And we worked with community organizations such as you all on the phone to make a difference. And that difference results in the data and the outcome improvements that we wanted to see. So I think if we take that same approach to our overall health outcomes and chronic diseases, we will see that same improvement. I think I went over, but I tried to go as quickly as I could to try to capture all the information. So I do want to thank the organization for pulling everybody together, because these things are so critical for getting the word out. And I thank y'all for having me this evening.
Thank you so very much, Dr. Phillips. Thank you so very much. The biggest thing is, please prioritize your health. And I feel like she was speaking directly to me. So thank you once again, Dr. Phillips. Once again, everyone, if you have any questions, please do not put them in the chat. Feel free to put them in the Q&A box. Please feel free to do so right now.
Well, if I can hop on in here, because I can tell you right now, my phone has been blowing up with comments about Dr. Phillips. Oh my gosh, she's awesome. This information is great. She's so impressive. I mean, everybody is, you've probably gained a few fans tonight, Dr. Phillips, I can tell you that. And so along those lines, I have a question that actually doesn't really have a whole lot to do with heart health, but I mean, in your bio, we just read that you took this job as Secretary of Health for the state of Louisiana a short time after Mardi Gras 2020, which I guess some would say that you stepped into this role at ground zero. How do you personally keep everything in perspective and manage the enormous responsibility of leading the state's largest agency? I hope that wasn't lost on anybody when I read that in her bio, the state's largest agency, period, much less during a global pandemic. How do you just talked about stress and stress management. You mentioned the things that we have coming at us. How do you personally keep everything together? I think we all want to take a page out of your book right now.
Yeah. No. I don't do the best job, which is why I say it's so important to have folks who hold you accountable. And you all are some of the folks who do check-ins on me. And I think that is so important. And so, as you mentioned, I officially came on in April, but I started coming down in March because of where we stood with COVID in New Orleans. And I will tell you, when I accepted the role, COVID was not really on the radar. And so you think you are on a mission for something very different than what I walked into. But I shortly realized that the purpose of me being here was very different and very intentional. And I think it was because of a higher being of me being here at this particular season for a specific reason in terms of equity and where we stood with COVID. And it was tough. I got a question. I did a presentation last Saturday, and I got a question in terms of a young lady asked me, a student, in terms of the most challenging thing coming back. And I shared with her sitting in the seat as a Black woman in Louisiana. And as I thought about it that night, it wasn't just sitting in this seat as a Black woman, but it was sitting in this seat as a Black woman here in Louisiana with the weight of every life in Louisiana depending on you during the season. And that was tough because you went home at night questioning everything you did, driving the team, because at the end of the day, when we were reporting out numbers, our death numbers, they were somebody's loved one. They were a neighbor, they were a friend. And sometimes it was my own family's numbers that I had to report out in those death numbers. And so that's heavy, probably heavier than anything that I've done in life, that you come back to a state that you love. Your family is here. Your friends are here. This is an organization I came in and began my career in as an intern. And so it really did feel like you had the state's lives depending on you. But I am happy that I was chosen to sit in the seat. The clarity of why I was here came very, very clear to me in terms of the work that we needed to do and to make sure that we were introducing equity around COVID in our vaccine distribution in terms of where we needed to be as a state. So that's a long way. In terms of the stress, I have much work to do around that. Physical activity, I have much improvement. I will tell you all that I have not done a good job in the last 3 years. So y'all should hold me accountable as well.
Be sure to.
Absolutely. So actually, Dr. Phillips, we've got a few questions in the Q&A. So one question, it's thank you. This is wonderful information. When should we expect to see the mental health centers or / urgent care centers?
Yep, and so it varies across the state. So one thing that we did with this particular project is sometimes when we do implementation of services, you may have it in a large urban area. We may have one in South Louisiana, North Louisiana. What we did this go around was say, okay, of these 4 services, we want one in every region of the state. So folks can have access. Again, it's not in every parish, but it's in each of the regions. And Louisiana Department of Health divides our state into 9/10 regions, depending what service it is. And so for us, for these services, it's in 9 regions. We do have services starting to stand up here in Baton Rouge. And so we have the contract is with Bridge Center here in the East Baton Rouge area. One thing that we do not have that is needed across the state is a central crisis line. So I talked about the suicide line, but we do not have a central crisis line for services across Louisiana. That is something we're working on, and you can expect to see that coming in this upcoming year, a central crisis line. I will tell you the other thing in terms of the 4 services, and I'll get you guys, I can send out a one-page flyer and email it to both chapters so you all can share that with your members as well so they can share it with others, is that what we're finding as we're trying to expand these services and increase access is workforce. And so I think we do have a responsibility as a department and the community partners is make sure we're introducing our youth to opportunities in healthcare of where they can achieve. I'm a firm believer, if you could see it, you could be it. And so making sure that we expose our youth, particularly our youth of color, to these healthcare opportunities. That is one thing we're definitely experiencing. We can add some of these services, but we really don't have the workforce across our state to implement them. So in the Baton Rouge area, we do have the services up and running. For some other areas across the state and some of the regions in North Louisiana, they're still up and coming. And so we have some work to do there. But I can get y'all a one-pager that lays it all out.
Okay, great. Thank you so much. So we've got another question. It says, can you please share more information on the blood pressure check spots and how to become a location?
Absolutely. So if you email me directly, I will make sure you get routed to the right folks in our department. My email address is Courtney, COURTNEY .Phillips, PHILLIPS @LA.gov. And I will put it in the Q&A for anybody who may have missed it once I wrap up.
Okay, got another question. So it's like this question is toward initiative. The question is, will there be any on the ground door-to-door initiatives for the mental health awareness like there were for the COVID outbreak awareness vaccinations? This person says, I had the pleasure of hearing for one of the COVID initiatives through Power Coalition and Charlotte Minor, and I found it to be very helpful for the communities.
So right now, in terms of the mental health, we don't have folks going door to door on that piece of it. I'm glad you asked that question because I do want, why it's not on the mental health piece, we do have our folks getting out and about trying to do more listening sessions and town halls to understand better, both on mental health as well as women's health. If you all recall last year during legislative session, we finally got created here in the great state of Louisiana, Office of Women's Health. And so that too will be coming to an area near you. It'll happen after legislative session. But when we talk about folks going door to door, I do want to hit something that I did not cover. this upcoming month in April, we will begin the Medicaid unwind, and you all will hear a lot more about that. I am happy to come to a meeting or wherever you need me and my team to be. During the public health emergency during COVID, for individuals who access and qualified for Medicaid benefits, no state did any renewals, meaning everybody who qualified on the roll stayed on during this current public health emergency. Well, the feds have now said, okay, now it's time for you all to begin doing those reviews of individuals who qualify for Medicaid benefits. What we don't want to happen in our state is that individuals who do qualify for the service to be dropped from the rolls because they don't have their updated email address. They don't have their updated physical address. We don't have their updated phone number. So they can't submit to us the proper documentation in terms of what they need to maintain those services. So we will be contracting and working with community organizations. A lot of them we did work with during COVID, of learning that lessons of how we got folks engaged and being able to keep up to speed with them. This is going to be a critical component for our state to make sure that folks who truly qualify for Medicaid services do not lose benefits. We are going to be working with all of our healthcare providers. You mentioned organizations like Together Louisiana, Power Coalition, working with our independent pharmacies, working with our FQHCs, working with I mean, I can't stress enough our churches, our councils on aging, to really touch every life. And if you're not somebody who is utilizing Medicaid benefits, we all know someone. You may work in a healthcare provider's office. You may have a student who's at the university. You may have family, friends. You might work with a youth organization. It is incumbent upon all of us to make sure that folks have access to this information and understand how critical it is for them to update their physical address, their phone number, as well as if they do have an email address. So thank you for whoever asked that question, because I should have highlighted that as a sidebar in my presentation.
Okay. Let's see. All right, we've got another one. How can educators facilitate increasing access to opportunities in healthcare? What age restrictions apply to children's community involvement in volunteer health service?
I don't necessarily know that there's a restriction. I guess it depends on the type of volunteer activity that they're doing, whether they're in a healthcare facility or they're at a particular event where you're highlighting certain community actions. I think just for healthcare, I mean, for educators overall, we work with the Health Education Coalition, AHECs, across the state, who will go out and about to schools. We started a program with them, my years are running together, either last year or the year before, where we go into schools as early for Head Start programs, where we do a white coat program. Again, we try to take a clinician from that community or a clinician of color to individuals going into underserved communities to say, you see it, you could be it. And they do a white coat program for the students and educate them on the different healthcare opportunities that exist. A lot of times we just don't know that it's a possibility or what's the continuum of healthcare professions that are available to us. And then making sure that we start linking up those students to mentor. So we do have contracts with entities that we do. If we have educators who are interested, again, that same email address I put in the Q&A, I will get you connected to our public health folks who can help facilitate some of that.
Right, and we'll do one more just in the interest of time. We'll do one more question for you, Dr. Phillips. Excuse me. As a Black woman in insulin resistance, what advice or resources would you give to help improve the well-being of those like me that drive and/or travel for a living?
I'm gonna let Dr. LaMotte answer that question as the health clinician versus me as the policy person. Let's pick another one for me.
Absolutely. Okay.
There's an easy yes or no one out there.
Now the question, does the blood pressure check locations check for diabetes as well?
If they are a co-location who requested that they want to serve as a dual site, they absolutely can. Most of the sites that I talked about for the 10 and the 6, they are not dual sites, but that is absolutely a possibility if they choose to want to be a dual site.
Okay.
And since my email is in that Q&A, if y'all have any questions that we don't get to on here, please feel free to email me directly. If I don't answer you in 1 to 2 days, just email me again. It was not intentional. That means I missed it, or I started an email and didn't finish it. If I don't hit you back in 1 to 2 days, just email me again.
Okay, well, we can certainly do that. And Dr. Phillips, we can also make note of the questions that we did not get to, and we can forward those to you as well. So maybe in our wrap up with the attendees, we can send out the answers. Perhaps we can ask our phenomenal IT team. We always ask them to do some things that seem almost impossible anyway. So why not add this to the list, right? So I would like to thank you, Dr. Phillips, for your time, for your expertise, for your leadership, your dedication to all of us in the state of Louisiana. Although it sounds as if we still have some ground to cover, I can honestly say that I know we are in a better place because of your leadership, and we thank you, my friend, my sister. I appreciate you for joining us this evening. On behalf of Baton Rouge Delta and our La Capitale chapter, thank you so very much for your time. Appreciate you. Y'all, Dr. Phillips is busy. She's got to run, so we're going to let her go. Okay. But thank you so very much. Appreciate you. Okay. Well, with that, we are going to move right into the second presenter this evening that I happen to know very well. Dr. Lance LaMotte earned his undergraduate degree in pharmacy from Xavier University College of Pharmacy in New Orleans, Louisiana. He went on to earn his medical degree from Louisiana State University School of Medicine in New Orleans and postdoctoral fellowships at both the Texas Heart Institute in Houston, Texas, and the University of Alabama at Birmingham. He has served the greater Baton Rouge community through his private practice for more than 20 years. He specializes in interventional cardiology with a focus on complex and high-risk coronary interventions, emergency cardiac care, minimally invasive cardiac procedures, and structural heart disease intervention, including transcatheter valve replacement. Dr. LaMotte has served as chief of cardiology at both Our Lady of the Lake and Baton Rouge General Hospitals. Currently, he serves as the medical director of cardiac rehabilitation at Baton Rouge General Medical Center. He is also a member of the Louisiana Emergency Response Network that oversees delivery of regional emergency cardiac care in the state of Louisiana. He is a member of Lambda Alpha chapter of Omega Psi Phi Fraternity Incorporated here in Baton Rouge, but he says his most valuable roles are as husband to yours truly, Kimberly LaMotte, and father to our adult children, Lance Jr. and Kristen Alexis, who is actually on in the audience tonight. So with all that being said, Dr. LaMotte, the mic is yours.
Well, thank you, Mrs. LaMotte, for that very kind introduction. I do want to offer thanks to the Baton Rouge Delta Alumnae chapter of Delta Sigma Theta and La Capitale chapter of the Links Incorporated for allowing me to speak, but everyone really knows that I was voluntold to do this. So I will do my part. So I'll try to share my screen so we can get started with the content here. So everyone, just bear with me for a second. And let's see, is that visible?
Yes.
So again, thank you. And this is a great clinical follow-up to what that great discussion that Dr. Phillips had with us, talking about disparities in our community. And as it relates to heart disease. And so this is Heart Month. And so this is an opportunity for us to highlight something that burdens us all. So we're just going to kind of jump right in. I want to start with a few case examples that highlight this very disparity. Let me try to do this. And so this is a real patient of mine who I met in 2010 after he presented to the Baton Rouge General Mid-City Emergency Department. He actually was driven by his family, and as he was checking in the waiting room, he collapsed. He had had several days of chest discomfort, and before he could really say much to the staff, he collapsed in the waiting room. And so this was the monitor strip that they were able to get from the time they applied when the emergency personnel got to him. So his heart was out of rhythm in this lethal rhythm called ventricular fibrillation that is actually very similar, not the same thing that Damar Hamlin had on the football field. So they were able to resuscitate him, at which time I was called to meet him, and we found that he was having a heart attack. So we brought him urgently to the heart catheterization lab and did an angiogram. And the image on the left highlights the anatomy of his heart vessel. There's a blood vessel on the back of his heart that was 100% blocked off. And we were able to successfully open it up with a stent, and he did well, at that point, and was able to be, successfully discharged. But of note, during that evaluation, his blood sugar was 495. For those of you who don't know, the normal blood sugar is about 100. So he had not been formally diagnosed with diabetes at that point. His kidney numbers were awry, as were his liver numbers, and his blood pressure was through the roof. So all these things manifested and culminated in this guy nearly losing his life. And so over the subsequent years, he has only sporadically followed up in the office. He's had multiple chronic medical illnesses, and he only showed up for his appointments intermittently. I did see him in December of 2021 when he, 11 years later, age 66, he had developed vascular dementia. He had had several small strokes. He was limited by gout in addition to the prior strokes, and had symptoms of congestive heart failure, and actually was then placed in a nursing home at 66, which we'd all agree is a young age. And this is a very classic presentation where, unfortunately, we always say we like to meet our patients in the office rather than on a gurney or the floor of the hospital like this gentleman. And so, but it highlights the fact that this burden of disease in our community is strikingly different than what it is in other ethnicities. And so this is a classic example of that. So across nearly every metric, our communities have poorer overall outcomes than our white counterparts. This is in contrast to another young man who came to me in the office setting after he had been having chest discomfort. He has a history of high cholesterol, and a few family members had heart disease. He's 41 years old and fairly well-to-do. He owns his own business, and we decided to do a stress test on him, which was abnormal, and brought him to the cath lab. And if you can pick this up, he had essentially the same blockage as that first gentleman, but his was found prospectively. We were able to stay ahead of it. He had not suffered a heart attack. So we got nearly an identical result with his artery being stented. Almost looks the same, but a very different presentation. So this kind of highlights how our patients can come to us in different fashions. So I saw him, I've seen him actually since this slide was created. He's still doing very well. He's still active in his health club. He's lost weight. He's very motivated. He has subscribes to a meal prep service. And, so just you look at the parallels that are drawn between these two patients, and I think it just highlights the core of what we're discussing today. And so this statement came out in an article in one of our cardiology journals from many years ago. It says, little has changed when these disparities in prevalence, disease management outcome were first reported. And that holds true even today. So heart attacks are our number one killer. Heart attacks, most people die in this country. It's the number one killer in the United States. So every 37 to 40 seconds, someone has a heart attack in this country. It is the leading cause of death, and it kills more people than cancer and respiratory illnesses combined. So it is estimated by 2035 that over 130 million US adults will have some type of cardiovascular disease. So in addition to coronary heart disease, which we just highlighted, that also includes valve disease, heart rhythm disturbances, arrhythmias, fainting, the list goes on and on. But with that, approximately 18 million adults have coronary disease, with over 800,000 heart attacks each year. So specifically talking about Louisiana, it is the number one cause of death in Louisiana as well. It accounts for nearly 1 in 4 deaths in our state, and we have the 5th highest death rate from cardiovascular disease in the country. And so, as Dr. Phillips has highlighted, oftentimes you can look at the statistics as it applies to the US in general, but in Louisiana in particular, our the prevalence is usually greater. So this accounted for over 12,000 deaths in 2020, cardiovascular disease did, and again, 5th highest death rate in the country. So if you look across different populations, if you look at, our African American population, and this slide shows death rates per 100,000 population. And so, 212 per 100,000 for African Americans versus 168 per 100,000 in the Caucasian population. That equates in the country of over more than 150,000 excess deaths relative to the majority population. So staggering. And so it's estimated that nearly half of African American families, half of African American adults have some form of cardiovascular disease, and we have the highest death rate. And so this can disrupt families. And many of you on this meeting can think of your own families where your family unit has been disrupted by cardiovascular disease and the implications there in terms of the family structure, just the flow, the dynamics, the income, your legacy, all that is impacted by premature death. And so this is to be respected. So I want to talk a little bit about some of the risk factors that leads us to some of these disproportionate numbers. So this slide shows the classic, what we call risk factors for developing coronary heart disease. The good news in this is that the majority of these risk factors are modifiable. And so high blood pressure, high cholesterol, diabetes, smoking are all things that, and sedentary lifestyle and obesity are things that can be impacted by lifestyle change. We can't change our age, or at least not in a good way. And our DNA, our family history can't be changed, but all of these other risk factors can be modified. So what can you do? So we talk, the American Heart Association talks about life's essential 8. And so the left side shows sort of lifestyle things that can be attacked, a better diet, increasing your activity levels, stopping poor social habits like smoking, getting adequate rest. And then the other things, just kind of knowing your numbers. So managing your weight, your cholesterol, blood pressure, and blood sugar. We'll dig into that a little bit. So regarding hypertension or high blood pressure, this impacts 50 million Americans, and worldwide, 1 billion people are impacted with elevated blood pressures. And overall, it's the 3rd leading killer in the world. In Louisiana, 1 in 3 adults has high blood pressure. And as we stratify this according to race, this impacts about 40% of African Americans versus less than 30% of other populations. And so it's much more prevalent in our communities. And there's a lot of variables that can go into that. And so what is a normal blood pressure? So if you look in the green, ideally you want it less than 120 systolic, or the top number, and less than 80 for the diastolic reading, or the bottom number. And so this also shows the different stages based upon where your readings fall. And so, 140 over 90 is high. 130 to 140 is still higher than where we'd like. And so this is much more stringent than what many people are used to. And I can't tell you, every single day, and my staff and I, we chuckle and we say, if we had a nickel for every time we tell a patient that their blood pressure is high, and then before we finish making that statement, it's often, oh, my pressure was fine when I left. It's your office, it's this, it's the traffic, it's this. But the point is, this is often called a silent killer, but we want you to understand that high blood pressure is not silent. It causes significant morbidity and mortality in our communities. So, I will agree that the doctor's office is a very different setting than your home environment. And we often don't make critical decisions about with just one blood pressure reading. So we encourage almost everyone to have access to a blood pressure monitor at home so that you can get used to checking your pressures. And it's helpful for us if you're equipped with sort of a range or some proof that your blood pressure trend is different than what we're seeing with that one-time reading in the office. And so high blood pressure, again, is not silent. It is associated with several end organ toxicities: stroke, heart attack, heart failure, kidney failure, and there's even something called hypertensive retinopathy, which can lead to blindness. And so almost every kidney unit that you go to, and if you talk to patients on dialysis, almost all of them had or have high blood pressure as part of their pathology that led them to get attached to that kidney machine. So what about blood sugar? So diabetes is a major risk factor for developing heart disease. In the US, this accounts for almost 10% of the population, where 34 million people have it. And that's 27 million people have a formal diagnosis, but in a frightening fashion, 7 million are undiagnosed or walking around with it. So if you're walking around, your vision's blurry, you're using the bathroom all the time, and you're thirsty all the time, then you should visit with your primary care physician and have an evaluation for diabetes. And even more staggering, there's thought to be 88 million people who are undiagnosed, who have prediabetes. And so, and this is estimated to worsen as the years go on. And so this is critical for us. Although I don't primarily treat diabetes, we often see the ravages of diabetes, because diabetes results in vascular disease. So it's present in 1 out of every 4 patients with a heart attack, and most diabetics will ultimately succumb to some form of vascular disease. And so just a few definitions, if there are different ways that this can be assessed. The hemoglobin A1C, which is an evaluation of the average blood sugar over the course of 3 months. You want that less than 5.7, and this shows the stratification. Normal is less than 5.7, prediabetes 5.7 to 6.4, 6.5% or higher is diabetic. A fasting glucose, sometimes if you've consumed a meal, or if there's some other illness causing some bodily stress, the sugar can be transiently elevated, but generally you want your sugar around or less than 100. And then there's oral glucose tolerance testing with those numbers as shown. And so every 17 seconds, someone is diagnosed with diabetes in this country. Our population is 2 times more likely to have diabetes than the majority population. So many of you have heard people say, well, I have a touch of sugar. Well, there's no such thing. You can't be a touch pregnant. Either you are or you're not. And so touch of sugar is not recognized by the American Diabetes Association. It is true that you're expected to follow a diet, but it's not maybe as stringent as some people are led to believe. But the objective in dietary modifications in our diabetic populations is to decrease the risk of vascular complications. Weight loss is often a corollary to modifying those behaviors. So what about high cholesterol? That's another risk factor for developing heart disease. It comes from 2 sources, either our genetics or what we consume in the diet. So the cholesterol is a necessary substance that our body produces. It's produced in the liver. There can be a genetic predisposition to excess cholesterol production, but there's a significant component that comes from our dietary habits. And so most of our cholesterol in the diet comes from animal sources, meat and dairy products. So this can build up to an unhealthy level that can ultimately lead to plaque buildup in any of the arteries of the body, particularly the heart, the brain, or sometimes the lower extremity circulation. So just, hopefully you are familiar with this stratification between the good and bad cholesterol. So the HDL, or high density lipoprotein, is the good cholesterol. You want higher levels of that, higher than 50 in women and higher than 40 in men. And the LDL, which is the bad cholesterol that builds up inside the arteries, you want to keep that lower, generally lower than 130 at a minimum, preferably under 100 for all, and less than 70 if you have established vascular disease or if you're diabetic, or the LDL. Total cholesterol should be less than 200. So we won't spend a lot of time here, but if you smoke, stop. Smoking is the leading modifiable risk factor. About 20% of us in this state are smokers. And, we see a direct correlation. I mean, and we see a person coming in with chest pain syndrome, and their smokers are antenna are way up. And we have a very high suspicion that they could be sitting on something dangerous. Most smokers start at a very young age. And these statistics show that many people even start in high school. And so, but the good news is that if you quit, you can reduce your risk, and being abstinent from cigarette use after 15 years approaches the risk of a non-smoker. And so it's not too late to quit. And we would challenge any smokers at this meeting to discontinue that habit, because it does pose a risk for your vascular health, in addition to exposing yourself to the risk of chronic lung disease, pneumonia, and various cancers. So, and this includes other forms of tobacco, not just cigarette use. So that can be extended to smokeless tobacco, electronic cigarettes, cigars, and pipes. So what else can you do? So we challenge you to become more active. Obesity is prevalent in our state, our community, and our region of the country. The Southeast tends to be the heaviest, population in the country. And so it's just, we enjoy our food, our culture, but we pay a price. And so just by some definitions, being overweight is related to your body mass index, which is your weight according to your height. So I have this table here. So if you just take a moment to see where you might fall. And so this table shows your body mass index is across the top bar. And if you would find your height on the left and go across to your weight in the middle, and then track it up to that BMI. So by definition, your BMI ideally should be less than 25. 25 to 29 is considered overweight. And by definition, a BMI of 30 or greater is considered obese. And so this is, there's a multitude of variables that go into obesity, because it is a surrogate risk factor for many of these other risk factors that we've spoken about. And so the Heart Association endorses 150 minutes of activity per week. And so that equates to about 20-30 minutes on most days of the week, or a couple of days of high intensity exercise a couple of days a week. So why is this even important? Because it can help you maintain weight. It can decrease the risk of some of these risk factors: blood pressure, diabetes, cholesterol, maybe even a few cancers. Excess weight can wear on your joints, which can put you in the vicious cycle of being unable to exercise and unable to lose weight, again, which can keep these risk factors uncontrolled. Activity can also build bone strength and decrease the risk of fractures from falls. And studies have shown that it can reduce the incidence of depression and anxiety. So this shows various intensities of exercise. So light exercise would be, carrying out your trash, maybe doing some yoga. Moderate exercise, such as walking, cycling, or shopping, and up to vigorous exercise, playing a sport, or dancing. So if you think of moderate intensity exercise as an activity that you can carry on while still holding a conversation, such as walking briskly, maybe doing some light yard work, shoveling, which we know nothing about, snow shoveling, which we know nothing about here in Louisiana, versus vigorous exercise, in which it's very difficult to hold a conversation if you're doing something like swimming laps, running or jogging, or playing a sport. And so just wrapping this up, just talking about diet, just being wise in our choices and limiting saturated fat and heavily processed foods. The diet should consist mostly of fruits and vegetables and healthy protein sources. Being careful how we shop. We tell our patients that there's probably healthier food choices in the periphery of the grocery store rather than the center aisles, where things are mostly in a box or can. And so if you're going to consume meat, maybe choose leaner cuts and avoiding processed forms. Things like bacon, hot dogs, sausage tends to be very heavily processed, and so that should be greatly limited. Limiting salt in the diet. Salt can have implications regarding blood pressure control, and our patients with heart failure, we are very stringent with their salt restrictions. Being careful with sugary beverages. It's a leading source of added sugars in the diet. And that includes also fruit drink, which typically have good healthy minerals, but it comes at a cost of excess sugar and caloric intake. And so even be careful with the coffee that you purchase. So black coffee is maybe neutral, but being careful not to add, the heavy creamers and sugars there. This shows the sugar content of many popular drinks. If you look at the number of tablespoons of sugar that might be present in a soda or typical juice drink, it's pretty staggering. So limiting that. And what about alcohol? That should be greatly limited. Alcohol can pose a risk of hemorrhagic stroke with heavy consumption, risk of atrial fibrillation, which is a very common heart rhythm disturbance, and just keep it in moderation, if at all. And so this picture kind of illustrates a typical diet that's prevalent in our community. It may look awfully good, and I tell you, there are some of us who enjoy eating like this on a regular basis, and this comes at a cost. There's a lot of maybe good-looking items on this plate, but it is not anything that you want to be consuming on a regular basis. There's a lot of carbohydrate and fat on here, and lots of trouble if this is your regular habit. So just again, decreasing your risk, control your blood pressure by reducing sodium intake, increasing activity, reducing alcohol intake, watching your cholesterol, watching your saturated fat intake, increasing activity, maybe increasing fiber, avoiding toxic behaviors, excess alcohol, tobacco use, and then keeping your blood sugar under control, and also modifying your weight. So as we talk about some of these disparities and higher prevalence of risk factors, we need a physician workforce to be able to care for our population. And so a sobering statistic is that although we account for 13% of the population, African-American cardiologists only account for 3% of the physician workforce. And so there's an organization called the Association of Black Cardiologists, which is kind of, an organization that many of us are part of, that is sort of a think tank that's meant to address some of these disparities. But within our communities, we are often at a loss in terms of options for having access to a physician that looks like us in our communities. We are blessed in Baton Rouge to have probably more physicians of cardiologists of color than many communities across the country. And so I invite you all to take advantage of that access that we have here. The implications are vast, though. Not having access to physicians to physicians that you trust can translate to problems accessing the adequate care that you need. So if you have a provider that does not really have the compassion and empathy for you, or if you, on the patient side, don't have trust in your physician, that is a powder keg, because ultimately your health is going to suffer. You may not be as open and willing to share your complaints or concerns with your provider, and this can result in missed or delayed diagnoses or treatments, and ultimately increased morbidity and mortality. This is borne out in many, many, many studies. I love my specialty because it is always at the technology is at the forefront. We have new developments and discoveries every year, something new, but our people do not have access to it at the rate that we need. So these studies show that despite the availability of this technology, many times our patients aren't offered it because they don't have the access. So as stated earlier, ask questions, make sure that you don't just take everything without understanding what your conditions are. If you have physical concerns, emotional concerns, make sure that your physician, he or she is listening to you and giving you the care and the time that you need. And that's it. Give us, we've got a few minutes for questions, and I'll be happy to answer anything that this has triggered for you guys.
Yes, sir. Thank you so much, Dr. LaMotte. Yeah, certainly have quite a few questions in the chat. They've been coming in almost within about 5 minutes of you starting. Okay, so the first question, because Black women are at a higher risk, should we go see a cardiologist annually like we do a primary care physician? Also, what about if you run low on blood pressure? Is that just as bad as high blood pressure?
So my answer to when you should see a cardiologist is really dependent upon your risk profile. You should know your numbers first of all. And so if you are a patient that has high blood pressure, high cholesterol, particularly if you're diabetic, then I would say our bias is yes. We would much rather meet you in the office setting when you're standing and walking than on an emergency basis, which is, what there's risk for if those things are unchecked. And so we do have a little bit of a bias when it comes to that. Most primary care physicians are capable of screening and understanding cardiovascular disease risk, but some of them have an inherent reluctance to refer to specialists because they feel like they're capable, and they are capable, but they feel like, well, look, yeah, you don't need to see them, you're fine. Well, the difficult call that we have to make sometimes is, hey, doc, your patient is here at the hospital. They came in overnight with a heart attack. They're fine, or sometimes they're not fine. And we just wanted you to know. And oftentimes they're surprised. And we're frankly not, surprised when we look at their risk profiles. And we always wish that we had earlier access to patients like that. So it just depends. The answer is it depends on your individual risk. Regarding the question about low blood pressure readings, there are many things that can go into it. The first thing would be looking at prescribed medications. Sometimes medications just may be needing to be reduced. Sometimes if there are other lifestyle changes, let's say if a patient's lost weight, that their need for medications may decrease. There may be other interceding conditions that result in a change in the blood pressure. But if it's chronically low, some people just have that in their profile and there's a specific investigation that we like to do in that setting. But usually things can be examined either between the diet or the medication prescriptions to try to explain that.
Okay. Next question. Once you start blood pressure medicine, is it a lifetime commitment, or can you successfully get off of the meds after having been on it for years?
So the reality is the majority of patients who are prescribed antihypertensive medications are on it for the long term. There are some patients who have either secondary causes of high blood pressure, like pre-existing kidney disease, or there's some other things that we often screen for. If those can be identified, then it can be reversible. Some people in whom the weight, the blood pressure could be from excess weight. If they lose weight, it can help reduce the need for blood pressure medications. We have some people who drink excesses of alcohol or have some other social habits that are contributing to the elevated blood pressure. If those can be mitigated, oftentimes those patients don't require the same amount of blood pressure medications to keep their pressures down, if any at all. So it is not an absolute that it's a lifetime commitment, but the reality is that many times it is.
Okay. So it looks like this is actually a two-part question. The first, has there been any correlation to heart disease in the COVID-19 vaccine? Are there any current studies being done in that regard? And then the second question is, there's been a high rate of younger people's heart stopping during sport, such as a Damar Hamlin that's been televised in recent times. Could this be related to heart disease instead?
So let me answer the second question first. So I don't know that the incidence of heart disease in athletes is necessarily increasing. Certainly, this has been at the forefront of everyone's thoughts with the tragedy that was witnessed by all. He had a very specific incident that is exceedingly rare, was probably something called commotio cordis, where there was just a force delivered in the right location in his chest at the right time of his, what we call the cardiac cycle, to cause his heart to suddenly stop. And so that has been well described. It is probably a little more prevalent in youth baseball because of the force that's delivered with that kind of projectile, which is why below a certain age, kids are required to play with a softer ball to decrease the risk of that. It's probably also a little more common in other sports like hockey or tennis. It's described in boxing, but the impact there is usually a little more diffuse. And in football, it's much, much more rare. So that's a kind of a rare isolated event. But if you look across the spectrum of cardiac events in athletes, sudden cardiac death, the most common entity is something called hypertrophic cardiomyopathy, which is a genetic condition that we know exists. And it's usually picked up on screening, examination, or EKG. Many of those patients will have murmurs, or certainly there are some very specific findings on their electrocardiograms that will maybe result in them being excluded from competitive sports. There are many other conditions that may need to be addressed in athletes, but may not necessarily prohibit them from participating in sports. But it just highlights, I think the biggest thing to take away is, in Damar Hamlin's case, the immediate resuscitation that was delivered that made the difference in this man, not only surviving this event, but being still able to have a full and productive life. Sometimes after a cardiac arrest, many times people are impaired if they survive the event. So that has brought awareness, and I know he is partnering with the American Heart Association to bring the awareness about the importance of everyone knowing how to do CPR. Regarding COVID and COVID vaccination, so COVID is such a complex illness that we're still trying to fully understand. It is like the wild card. So COVID can do just about anything. Specifically, things that we have definitely seen are a higher incidence of blood clots that tend to occur more so in what we call the venous system. So clots that can kind of start in the leg, travel, either stay in the leg or can be dislodged and travel up through the heart and lodge in the lungs, which we call pulmonary emboli. So that has a definite association. There have been some other things as it relates to the heart that we have seen. There's a higher incidence of atrial fibrillation in people with more aggressive forms of COVID. Those who are hospitalized, particularly if there's significant respiratory involvement, those patients have a higher incidence of atrial fibrillation. In terms of other specific impacts on the heart, this term myocarditis and pericarditis, which people have heard of, has been around forever. It has come more to the forefront of discussion as there is a slight bump in the incidence of myocarditis with COVID vaccination. And it's an overall low incidence, but within that low incidence, if there's a population of people who might have a slightly higher incidence of that small group, it's young men. I actually saw a young man yesterday who had gotten a COVID vaccination on a Saturday. On Monday, he was unable to go to work. He had pain in his chest, extreme fatigue and shortness of breath, and he was evaluated at one of our local hospitals and has largely recovered. I took an ultrasound picture of his heart yesterday, and his heart's squeezing fine. And so most of those people will recover. As a medical community, our position is still that we do believe that the benefits of vaccination far outweigh any small risks across the population. And if you have an individual exception or excessive risk regarding vaccination, that should be discussed with the healthcare provider. There's so much noise out there that you really have to filter through it all. I personally have been vaccinated and boosted.
Okay. All right, Dr. LaMotte, we've got about 5 more minutes. So we're kind of going to do like a rapid fire portion because there's so many questions. So I'm going to try to get as many in as I can. All right. Okay. This one, my son is 11 and his primary care physician said his cholesterol was a little high. What are some things I can do to eliminate, or what are some things I can eliminate as we already do not drink sodas and fast food is minimized?
Yeah, so high cholesterol in 11-year-old, we are very hesitant to start an 11-year-old on cholesterol lowering medications. At that age, many times the diet is very, haphazard. I mean, who didn't eat fast food as an 11-year-old? And so we really have to establish some good habits within the family so that everyone's involved to decrease the amount of saturated fat in the diet. And so, most of the cholesterol is going to come from animal sources, so meat and dairy. If that can be limited, dairy should be low fat or non-fat, or even some, milk substitutes to decrease cholesterol intake in terms of dairy. And meat should be, either plant-based You consider plant-based protein sources or choosing leaner cuts like fish or poultry preferentially.
Okay. And then are there any new technologies out there to help pinpoint blood clots? If so, which screening should we request?
Well, really, we don't routinely screen for blood clots unless someone has symptoms or concerns. So in a normal, healthy person who's got no symptoms, screening for blood clots, the ones that we just spoke of, that's not typically done. If the question is more about, developing vascular disease, like, blockage in an artery, we have a multitude of ways that we can assess for that. So typically in our office, we see someone who has risk factors for coronary disease. The most important thing is taking a good history. So if there are symptoms, that can often steer the evaluation in one way or another. If there's no symptoms and a totally asymptomatic person who may just be interested in their vascular health because of a family history, there's not a uniform approach with many of us. If the person's of appropriate age, we may consider a stress test. We'll do a basic examination, an EKG, and if warranted, additional testing, ultrasound. And there's even some CT scans that can be done in the right patient population. That's typically reserved for people who are maybe a little bit older, probably 40 and above. Less than 40, we probably, would stay away from those radiation-based tests. But in terms of screening for blood clots like those that can develop in the leg and travel through if you're having pain or swelling, yes, there's targeted evaluation, but that's not anything that we routinely do testing for. You should have during a good physical examination, those things can be detected though by an astute physician.
Well, I'd like to jump in and say one comment. Just as my phone blew up, just as my phone blew up with comments about Dr. Phillips, my phone blew up about your BMI chart. Well, that's a no. That's a no. I got several comments about the BMI chart. Sweet tea at Starbucks and CC's, the food, the alcohol, but it's all good. It seems as if everybody is taking your suggestions and they appreciate the cultural sensitivity that you bring to the conversation. On that note, talking about the cultural sensitivity, and you brought up the fact that the statistics about African Americans in medicine in general, I see Dr. Grimes on here as well, and African Americans in cardiology. And you mentioned the social determinants of health. I know the answer to this. Did you receive any formal training on health equity, health disparities in your medical training? You did not.
I never.
Cultural competency. Same thing with Dr. Grimes.
Never heard that term. Never heard that term until recent years.
So for that reason, I wanted to pinpoint that for everybody, because I advocate for people to representation matters. Let me say that representation matters. And the fact that, we can all take this with, pardon my pun, a grain of salt, talking about looking at the BMI. I got people saying, oh my God, I went up, to the BMI chart and I'm only eating carrots, and forget that, just air. I got all kind of comments in my text messages, but it helps to have, like I said, representation matters. And also there's a concept I want everyone to be aware of and familiar with, and that is health literacy. It has absolutely nothing to do with your literacy, whether you can read. It really doesn't have a whole lot to do with your level of education. Your health literacy is how you receive information from your medical providers, how you interpret that, you process it, and you use it as the patient to be a part of your healthcare team. Dr. LaMotte, Dr. Grimes, we love you all, but you all can recommend. It is ultimately the patient's decision as to what they are going to do. Unfortunately, the literature is rich with people who have had surgeries and didn't even know that what they were having surgeries for, or that they were going in for an operation. So I would encourage everybody on tonight's Zoom to please be an active participant in their care. And an easy way to do that is to say, now, Dr. Grimes, hold on, let me make sure I understand what you're saying. I believe I heard you say fill in the blank, 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 and you either as the physician amen that or say, well, almost, let's go back to this point, so that people are intimately involved in their care and it's they're in control. They are in control. I just wanted to bring up that point. Dr. LaMotte, we still have questions, and we're just going to have to call it in the interest of time right now at 7:32. So we appreciate your time this evening, even though you were voluntold to do this. We appreciate your time on behalf of of myself. Let me say that in front of everyone. Ms. Matos, would you like to close us out, please?
Absolutely. Once again, Dr. LaMotte, thank you so much for your time, as well as Dr. Phillips. I know she needed to get off. And to Mrs. LaMotte's point, you know, in the interest of time, there's so many questions, and actually they're still coming in. But we're going to go ahead and stop here. We're going to do our best to try to get these questions out and answered for you. But Dr. LaMotte has his information still up on the screen. Dr. Phillips had an email address as well. So hopefully you guys are able to levy some of these questions when you can. Thank you all so much for joining us this evening. Please make sure that you prioritize your health. Do everything that you can to take care of yourself, take care of your family members, your friends, and just take care of each other. On behalf of the Physical and Mental Health Committee, as well as the Social Action Committee and the entirety of the Baton Rouge Delta Alumni Chapter of Delta Sigma Theta Sorority Incorporated, thank you all so much for joining us, and enjoy the rest of your night. Thank you.
One last thing in closing, there was a post that someone put that there is going to be a free health checks at a free clinic April 14th through the 16th, and that everyone can sign up at the Baton Rouge Love Heals Free Clinic. Baton Rouge Love Heals Free. If everyone can please take a look at that, free health checks. Just throwing that out there for everyone. Thank you, everyone. Good night.